Hello, my name is Ricky Alten. I'm heading the Department of Internal Medicine and Rheumatology and Clinical Immunology at Schlosspark Clinic, Berlin, part of University Medicine Berlin, Germany. Today, I will be presenting highlights from the poster Antibody Response to Pneumococcal and Influenza Vaccination in Patients with Rheumatoid Arthritis receiving subcutaneous abatacept, which was presented at the 2013 EULAR Congress in Madrid. Today, there are not so much data available concerning vaccination in patients on biological treatment. We have collected data for methotrexate patients in the last years, and nowadays we use vaccination in these patients without any fear. Concerning biological therapies, there are big differences between, for instance, the B-cell depleting therapies, the TNF therapies, and also for compounds like abatacept. So it is of high value to get more data on this. And as we have introduced abatacept subcutaneous formula since a shorter time period, it made a lot of good information to the scientific community how the immune response was in these patients, as we already have got some information in patients who were for longer time periods on IV treatment. So this is the first time that data were performed in patients who were on subcutaneous abatacept. And what is also very important is that the patient population is representative of the patient population which we treat nowadays in our clinics or in our outpatient praxis for rheumatology. Patients with a short disease duration, but they have mostly high disease activity, and after a short time of period, they are nowadays, due to our EULAR algorithm, put on biological therapies. One of the most used biological therapy in these patients is abatacept. So to collect data for this patient group and to give confidence to these patients whether vaccinations can be used without any safety concerns, and also with the other information concerning mounting a relevant immune response, is of high value for the scientific community. To give some outline of the data which were presented in the poster, first of all, we have to see why the study was done. The study was done to get more data on the status of vaccinated patients on biological treatments. There were minor studies which were performed before, which got some interesting data on patients with abatacept IV treatment. But what was new with this poster is that here we can also have data of patients with subcutaneous treatment. So as we have seen, there were patients included from one big trial, the so-called ACQUIRE trial, where subcutaneous treatment was compared to IV treatment over 6 months. And the other group were the patients from the ATTUNE trial. In this trial, patients were included which had already a 4-year treatment with IV abatacept. So to make these two groups different is 1 point disease duration. The ACQUIRE population has a much shorter disease duration compared to the longer disease duration in the ATTUNE trial. So the patients with no antibodies at baseline were tested and retested at day 28 for pneumococcal and influenza, whether they had mounted a relevant immune response. That was the objection of this trial. So if we go to patient population, it is a typical patient population for patients with rheumatoid arthritis. They have a high disease activity, more than disease activity score above 5. More than 90% of the patients were treated with concomitant methotrexate, and also they all showed relevant C-reactive protein elevations. So what you can see in the poster and in the collection of our data is that there were patients which had no protective antibodies at baseline. And the other group performed already protective antibodies at baseline. And concerning pneumococcal vaccination, over 70% of the no protective group mounted a relevant immune response. And also for the influenza vaccination, the immune response were above 60%. Those patients who had already protective antibodies had, like expected, a lower response, but even those group had a response to pneumococcal vaccination above than 40%, and for influenza more than 30%. So we also performed a confounder analysis, which is shown in table 4. And by this analysis, we could detect no differences concerning methotrexate co-medication with steroids, and also with age, which is a very relevant question in this population. So concerning safety, there were no serious adverse events. One serious adverse event that happened in the influenza group was not related to treatment or to vaccination due to the opinion of the investigator. So what is very important also and noteworthy, that there were no relevant autoimmune events during the treatment as well with abatacept, but also as during vaccination. So to summarize, the major points is that the majority of the patients without a protective antibody level mounted a relevant immune response as well for pneumococcal as for influenza. So the majority of all patients reached a protective level of vaccination. There were some limitations that the relative low number which were included in this trial limit the results. So there were also other patients which were only treated for 3 months before the vaccination. So this is a rather short time period. But when we understand the mechanism of action of abatacept, then we can say that the co-stimulatory molecule does not prevent the forming of relevant antibodies to vaccination. So we can conclude that the use of pneumococcal and influenza vaccination in patients treated with abatacept seems clinically justified. The efficacy and the safety for these vaccinations are consistent with the data we have collected already for the IV treatment for abatacept. There is one interesting point, especially in the winter season, which is addressed by our patients when they ask how long the duration of the vaccination is lasting, the protection, compared to their status before they were on biological therapies, and also whether it differs on which biological therapy they are. And the knowledge on vaccination in rheumatology is rather new. So we also are pioneers in collecting more and more data on this. There have been nice publications, especially on the B-cell depleting therapies, but there are not so much information concerning TNF-alpha therapies in patients with rheumatoid arthritis. So it is of high value to get new information on the protection duration of the vaccination. And what we say is that as our German government is recommending that the vaccination should be repeated every year. And there is no difference between patients with rheumatoid arthritis who are on treatment or those patients who are not treated. Actually, the uptake of vaccination in Germany is very low at the moment. So just today, there was an important information in the newspaper that our German Minister of Health has decided to make it a law, a regulation by law, that children should be vaccinated for measles. So it is highly discussed in the public because I don't know why, indeed, but there is a trend that especially people from the green wing do not like to have their children vaccinated. So actually this raises big problems. And what is our recommendation now for patients who are put on new treatments by the rheumatologist in collaboration with the GP should get a so-called vaccination status, where everything concerning vaccination is checked and put into a little booklet and recorded, so that at least we have information how the status of these patients are. So this is a new movement that we collaborate more with our GPs, because other surveys, for instance, in Germany showed that only 20% of the patients with rheumatoid arthritis, which came to a center in the western part of Germany, had a sufficient IMF status. So there is a very, very big problem which will arise when these patients really get infections in a broader area. So to come back to my concrete question, we can say that the patients who got these vaccinations with pneumococcal and influenza and have mounted relevant immune responses really are protected for the time being for at least 1 year. So the other thing which is also of high importance for the patients is their disease status over the years, and especially their immune system and their immune response, which is not only altered or damaged by the disease itself, but probably partly not only restored, but changed by different treatments. So we really have to know when we start treatment of our patients how their vaccination status is, and also how the antibody response is when starting on a new treatment. Actually, it is not very clear whether the rheumatologist should do this or the GP, because it is not regulated. And up to now, the rheumatologist only cared for those patients who were put on B-cell depleting therapies. But I think a paradigm shift will come when the rheumatologist, at least as they care also for the biological therapy, have to take into account the vaccination status of the patients and to make records on this. So what we have seen also, and this is possibly due to the specific mode of action of abatacept compared to other biological therapies, that the time patients have received abatacept did not prevent or did not hinder to mount a relevant immune response. So the immune system seems to be intact also after a long time period of treatment, like the data from the Attune population have shown. The other thing is that the population which we see nowadays in our clinics is totally different from the population we have seen, for instance, 5 years ago, concerning progression of the disease, concerning severity of the disease. And this is also reflected by the fact that most of the patients are diagnosed early nowadays. So, and they are really treated early due to the principle of treat to target. And so the high disease activity, which we have seen for years and years, which really incapacitated patients with rheumatoid arthritis, is nowadays nearly no more seen in the clinics. And I saw, for instance, 30 patients today on my round, and there was only one patient of this 30 patients with rheumatoid arthritis, which has really massive swellings of the fingers and other joints. And most of the patients are really reduced to low disease activity, and some of them already reached remission. So to come back to the question is that the severity of the rheumatoid arthritis, which we have seen before, is no longer day to day in our office, but it could influence in the process when steroids are used in a high dosage, also the immunological response. But normally we have patients which we see with the disease activity when they are treated below 5 disease activity score, and also the CRP is not more elevated than mostly 2 or 3 times. So the feature of the disease has changed. So this could also change the approach for vaccination. My advice is to check the vaccination status in the beginning. And like we talk with all patients on pregnancy planning and family planning, the discussion on vaccination should be included in one of the first 2 or 3 visits to make really a plan and to get an outline for the whole patient situation, at least for 1 or 2 years.